Parkinson 25. It's 25 things that you can do whether you have Parkinson or not. And so we talk about water, we talk about air, we talk about food. 4 is exercise. It's like a drug. Number 5 is sleep. And since it's different, you sweat different with Parkinson, you have a higher risk of melanoma, twice the risk of osteoporosis, thinning bones, and osteopenia. More men than women get this, and people forget, can men get osteoporosis? All the time. Veterans and Veterans Care is one of the Parkinson 25. There's a higher incidence and prevalence in our veterans. We need to take care of them at home and abroad. The book opens up with 2 young women. They both went to the United States Air Force Academy, and they both ended up with young onset Parkinson in their 40s, diagnosed within like a month or 2 of each other. And their story is not unique. There are lots of people that were exposed and lots of families that are on the basis. When we think about Vietnam, we think about what was Agent Purple, which was before Agent Orange, which is what Colin Powell was exposed to Agent Purple. He got Parkinson's disease. Let's just acknowledge it and let's give the veterans care, but then let's also do all the things we can do to protect and prevent our next generation of veterans.
Aging is a journey filled with questions, and no one should have to navigate it alone. Welcome to Thriving to the Finish Line. For today's episode, we're honored to welcome Dr. Michael Okun, a nationally recognized neurologist, New York Times best-selling author, and distinguished professor and director of the Norman Fixel Institute for Neurological Diseases here in Gainesville, Florida. Recently recognized as a 2025 highly ranked scholar by Scholar GPS, ranking number 1 in Parkinson's disease and number 2 in deep brain stimulation, Dr. Okun joins Shannon Miller, owner and founder of the Miller Elder Law Firm, for a thoughtful conversation about neurological conditions affecting older adults and how education and planning can bring clarity and a peace of mind to families.
Welcome to our podcast. I'm Shannon Miller, and I'm here with Dr. Michael Okun. And Dr. Okun is the director of the Norman Fixel, am I saying that right?
Yes, Norman Fixel.
Institute for Neurological Diseases at UF Health, and also a national, or is it the national medical advisor related to Parkinson's Foundation?
Either one. I answer it to anything. I have a 16-year-old and a 17-year-old, so anytime anybody wants to talk to me, I'll answer. So,
all right, great. So I think the thing that I want to talk about first is really where the Fixel Institute, kind of came from. Like, I know that you and Kelly Foote were like in medical school together. Is that right? Or were you doing your training together?
Yeah, we were residents together.
Okay.
So after medical school, Kelly was a resident in neurosurgery. I was a resident in neurology. And so we knew each other during residency. And then, as we went through our training, he went off to Grenoble, France to try to learn a new procedure at that time was starting to emerge. And the pioneer was this guy named Alim Benabid. And he was in the mountains of Grenoble, France. And so Kelly went there for 6 months. While Kelly was there, I spent 2 years at a place called Emory University studying with Malin DeLong and his group, which was an amazing experience for me, learning about the circuits of the brain and how the brain talks to each other and learning how to alter those circuits. And then toward the end of my time there, Kelly was coming and he was supposed to be paired up with the neurosurgeon there at Emory. And it turns out the neurosurgeon at Emory, very famous, Roy Bakay, moved to Chicago, which happens. And so when he came, we actually kind of swapped places, and he was there for a few months, and he was doing mostly the neurology side with my mentor, Malin DeLong, and learning that side. And I was doing more of the surgical side. And so in some ways we kind of knew each other's job. And we decided to move to University of Florida. And one of the reasons that we did that was that we realized that right around the year 2000, we're going to date ourselves now, there was this thing called the census. And we looked at the census numbers, and the census numbers suggested that the diseases that we wanted to study, like Parkinson's and degenerative diseases and dystonia and other things, these things were growing like crazy. They were growing a lot because of age. And if you looked at that time, the three states that were leading in people over 65 in that age group and leading that population explosion were Florida, Texas, and California. And in fact, we were moving up on the list of things like most common places to see Alzheimer's. We were sort of starting to get into the top 10 at that time. Fast forward now, we're like number two and closing on number one now, right? So that calculus was right in the sense that we could see there was going to be a lot of growth, a lot of need, a lot of people to help, a lot of people to impact. And so when we started here at University of Florida, our idea was fairly simple. We thought, let's get everybody under all one roof. Let's take care of people. Let's make the person with the disease or the patient the sun and orbit around the patient. That's how we've started. We always come back to that. And we built around that. So we built, the mechanisms for great patient care as well as access to research community, all the things that I think we need to be thinking about for chronic diseases.
And let me talk about that a little bit. We were out at Fixel yesterday touring, and we started in the speech pathology side where there was actually like a fluoroscopy to do the swallowing, like some different and higher tech tools that were being used. And then we see that, really these appointments for follow up are happening for Parkinson's like every 6 months, it sounds like.
Yep.
And during that time, you're going to see everybody. You're
Yep.
going to see your speech pathologist, you're going to see your PT, your OT, your nutritionist, your psychologist, your physician, your psychiatrist, like everybody in a couple of days. So you may be traveling from out of state or from far away, and you're going to get all of your appointments within a very short time period. And the reason that you guys are saying like this is patient-centered care where the patient is the sun and everybody is coming to the patient is because that's really the idea here is that you're going to take a couple days out of the life of the patient, get them to get tuned up, see what's going on, what adjustments need to be made, and then send them back out into the world to continue whatever plan you've created during that meeting.
Yeah, so a couple of key points that I don't think anybody's going to be shocked that in this healthcare system and in most healthcare systems you're lucky to get parking, or much less see like one person. And so when you have a chronic disease, and one of the things that we dug into when we were writing on this book and our last book as well is you have a chronic disease, we're just doing it wrong. We're moving the chess pieces wrong, and we need to understand how to rotate the right services in and out at the right time and to have plans. We need to have a plan for everybody and a model. And so, although it was ambitious and it was well meaning to say the patient's the sun and we should all orbit around the patient, we now realize that that model had to evolve. And so we've now evolved that in the Parkinson plan. And we talk about this being a more of a universe model. And so the person with disease is the sun, right? And then what's the closest planet to the sun? It's Mercury. That's going to be the caregiver and care partner, and Mercury is going to catch the heat, right, of being next to the sun, right? It gets tough being a care partner. More than 50% are going to end up with caregiver strain with diseases like Parkinson at one time or another. So your chances are very high. It's a very difficult position to be in. And at the same time, you're Mercury, so you're the messenger, right? Mercury means messenger, right? In Greek, right? And so you're the messenger to all the other planets. And these are all the other things that are in your orbit, everything from geriatricians to internists to, as you mentioned, speech therapists, physical therapists who need to come in and out and be an orchestra, in the right way.
Yeah.
And then we have Pluto. So Pluto is still out in that, and Pluto's the almost planet. And Pluto is the stigma. 25 to 50% of people are still going to hide their diagnosis with Parkinson, which is unacceptable. Okay, in the world that we live in, we should be embracing everybody with diseases, particularly when we can do such a great job of if we get them the right care model and the right care plan. We're not taking advantage of our satellites, so that's telemedicine, moving care into the home when we can. Sensors, I've got multiple sensors. I've got a sleep sensor on me. I've got watches. I've got 3 of them on me right now. We're not taking advantage of those new technological things that can help us manage people. We've got the stars, which are, all of the support things. So all the organizations, all the information that you put on the internet for people to learn about elder law and things. We have to be giving appropriate support to people. So those are the lights. And then there's the asteroid field. And the asteroid field is, right, like, you know, the parking, the insurance, the access, the coordination. And there's a story in the book that's from a movie called Star Wars that most people have seen. And Han Solo and Chewbacca are flying this gigantic, spacecraft called the Millennium Falcon through the asteroid field, and they're asking the question, "What are the odds we're going to survive this?" That's about the odds it is of getting successfully through this with Parkinson disease or other neurodegenerative diseases in our system and in chronic diseases. We're doing it wrong. We figured out how to do it in HIV and some of cancers. It's time for us to wake up and create a more universal or universe-based model so we can move our chess pieces the right way. And then just to build on one thing that you said, which is you saw Fixel and you saw how all these elements work. Some people will come in from all over the world. So we have folks that come from every continent except for Antarctica, and so they visit Antarctica, but they don't live there. Have you right? And but when they come in, we may do a day or two. But then we have other folks that will come in, and we're able to coordinate what they need when they need it. Okay, which is the sustainable, practical of what we talk about in healthcare, moving things in so we can decrease the billions of dollars a year that we spend on falls and hip fractures and mortality and nursing home placement. So we getting people the care when they need it. So moving beyond the patient is the sun, which is a great ambitious model. And of course I love it and I still say it to how are we going to move our chess pieces like we've done successfully in HIV and in cancer
Yeah.
to provide the right care.
Well, and I also think one of the things that we saw yesterday, and one of the things that we haven't really hit on, is how all of the care providers communicate with each other. Like we look in this conference room, and there's all these desks with people sitting at it, kind of talking about, what happened with this one patient, that one of them saw them for this and another for this, and that whole,
Yeah.
interdisciplinary. Because what we find a lot of is that, like, the doctor at the skilled nursing facility is taking you off the Parkinson's drug and put you onto one of their synthetic drugs that they only have to give once every 4 hours because 'cause you're in a skilled nursing facility.
Right.
So they think this is just as good as that drug that they've been on for the last 7 years, and then what we see is this, come decompensation, and we
Yeah.
see an increase in symptoms, and
Yeah.
it's very frustrating that we don't have that kind of communication that we're seeing at Fixel, that we're, the universe outside of this universe that you're talking about is all over the place. And some doctors remove them from this medication and put them on a different one. And, that you've got a lot of physicians who do not diagnose
Yeah.
Parkinson's. And, the client will come in to see us, and we see the shuffling and the small signature on the retainer agreement, and we see the frozen face, and we're like, "Have you?" "Well, I don't have tremors,
Yeah.
so my doctor doesn't think I have Parkinson's." And it's like, "Oh my gosh."
Yeah. 1 in 5 people don't have tremors. Even when we give the diagnosis, we do such a poor job when we give a diagnosis. This is a moment in these people's lives that's going to live forever. It's going to be imprinted on their brain. You have Parkinson, those 4 words. And yet, when we give it, we know because we've done our homework in asking people what happens, after that. They believe they have Alzheimer's, ALS. They're just going to compare it to things that they know, brain tumors that are really bad. And there's actually so much that's treatable, right? With this. And so helping people to understand from the get-go, get out of the box and realize that there are things you can do to have a great life with Parkinson, but you got to get the diagnosis right. And then so many people in society hiding the diagnosis because of stigma, and then thinking about how do we create a plan. And I think having a plan is really important. And I always tell the story of my son Jack when he was in second grade. We were playing chess before him going to bed, and I'm not a bad chess player. Played with my dad growing up, but I'm playing this second grader, and he beats me in the first game, right? And then we reset the board, and he beats me in the second game. And then we reset the board, and this is all before one time before bed in the second grade. Third game, he's beating me, and he says, "Dad, you know what your problem is?" I said, "Okay, Jack, tell me what my problem is." And he says, "Your problem is you don't have a plan." and I come in to play you, and I come in and I have a plan. And so when it comes to care and Parkinson, we need a plan. When it comes to Parkinson in general, our plan is not a good plan because we don't have one. And that was one of the reasons that we wrote the book. The P is prevent, the L is learn why. Why does it start? Why does it progress? Why does it spread? The A is the amplification of voices and the changing of a care model. So moving those chess pieces differently for the care model. And the N is the navigation of new therapies. And if we don't have a plan and we don't have goals and we don't measure them, where are we going, in the disease? So looking for practical, sustainable solutions so we can pivot and create an inflection point in this disease.
And I think on that, I think one of the things that people don't know is that when they delay the diagnosis, when they delay becoming, really getting on the medications, that you can lose more if you wait. And that does seem to be something that is relatively unknown. It's like, oh no, well, if I have Parkinson's and I just
Yes.
wait a couple of years,
Yep.
then it's going to be fine. I'll just get on the meds then. Like, I don't need to do it now because I'm still a teacher or I'm still, like they just go around with one arm not working
Yeah.
and,
And
and,
we
and in
talk
denial.
this,
Yes.
and it's and people should be skeptical. Okay, Shannon, they should
Yeah.
totally be skeptical. I encourage people to be
Yes.
skeptical. We wrote the book, Ray Dorsey and I, we go back and forth over 2 years. Like, everything that we say, every sentence, every word, we should be skeptical in this of everything that we hear. And so when people, are interacting with doctors, and by the way, the doctor is not the center of the universe, it's the patient, right? And all the other people that are around should be on equal footing. But when we tell you something, like if you're reading on the internet, there's tons of information that says these Parkinson drugs, they stop working, they're bad, they're toxic, and all these things. Well, I've worked as the medical advisor and medical director for Parkinson for almost 2 decades. It's one of the most common questions that we get, and we now have data. Drip, drip, drip. I call it the drip, drip, drip of data. Data from Africa, data from Italy, data from the US, data now from a major study in the New England Journal that was published in Europe that tells us that the outcomes, when you don't have medication versus when you do, and there is no effect. And in fact, the effect is worse if you delay medicines. You don't get a gold medal. You don't get an Olympic medal
Right.
for delay. So then you lose all this good life that you have. We can't stop the disease from progressing. We're working on those types of therapies.
Yeah.
But people need to know this. They should be skeptical. They should ask questions of their providers. And we're just not doing a great job of getting information, and it takes a long time, I think, to put that information out there in the right context. And I'll tell you, it's an interesting story because having lived it around the 2000s, all these new Parkinson drugs were coming out, these new expensive drugs that were tickling the dopamine receptor called dopamine agonists. And a lot of this, and there was an editorial in Lancet, and a lot of the gods of Parkinson,
Right.
the gray-haired gods of Parkinson would tell you, like what was going on. They talk about there was such a push, of people to get these expensive new drugs. It turned out to be less good than dopamine and to cause side effects, impulse control disorders, and things we didn't know about at that time. But there was such a push, and people said, "Don't use this," you know, and it actually further pushed people away from getting on the right medicine. So people that are listening should know there's nothing that better that you can do for yourself than to be optimized. And it's not necessarily having the purple, the red, the fuchsia pill. It's having the right pills, the right dosages, the right timing, and the disease changes over time. And so getting that care and that expertise makes a huge difference. And then rotating these care specialists in at the right points, huge difference in people's quality of life.
Okay, I want to come back to that, but the basic issue with Parkinson's disease, if I'm understanding it correctly, and I hope you can kind of explain this for our listeners, is an inner it like if it's a problem with the dopamine releasing, right? There's something that's stopping the dopamine from releasing.
So when we think about Parkinson's,
Yes.
and we just try to kind of paint that picture for
Mhm.
folks, we used to paint this picture of, you're missing this chemical called dopamine, right? And dopamine's important for movement, important for emotion, important for learning and everything. And so this is bad. This is sort of the preordained, kind of Bible of Parkinson that most people know. If they knew a little bit about it, they'd say you're missing dopamine and you have a tremor. Turns out it's much more than dopamine. It's much more than a brain disease. And 1 in 5 people, as we talked about, don't have a tremor, right? So I think we have now sort of said, look, we were wrong, like as a field, as a specialty. Here's what Parkinson is. Parkinson is a disease that involves loss of some of the chemicals in the brain, dopamine being a key chemical, but there are also other chemicals. Not important we know the names of them, but things like norepinephrine and serotonin, you may have heard some of these things. So multiple chemicals, multiple circuits, not just dopamine that connect to things that are important for thinking, for mood, for behavior, and for movement, and can cause tremors. The other thing that we've learned is Parkinson isn't just a brain disease, it's a body disease. And so we see Parkinson in the skin. We see Parkinson affecting the bones. We see Parkinson in the gut, and in the diets. And so even when we look in some of the new diagnostic tests, we're starting to look at all these other different body tissues and we're realizing, oh, geez, we told everybody Parkinson is just a brain disease, but it's actually also a body disease. And we have to think about other aspects that are tied to Parkinson beside just the aspect of the brain. So when we teach people about it, we talk about you can have symptoms like tremor, stiffness, slowness. You mentioned the slow handwriting, those types of things. So that's, sort of one aspect. And then 1 in 5 people don't have tremor. But the more disabling things, Shannon, in this disease are actually depression, anxiety, demoralization, and thinking issues. And not everybody has the same, group of these. And I remember once being at the White House and giving comments about Parkinson and saying Parkinson is probably the most complex disease in clinical medicine. It has over 20 of these motor, tremor, stiffness, slowness types of symptoms, all these non-motor symptoms like depression, anxiety, sexual dysfunction, sleep,
Apathy.
apathy,
Apathy is one I see all the time. It's like
apathy.
not wanting to do anything, and you're like, "Oh, no."
Yes, so very common, right?
Yeah.
And then also we see issues with sleep and other aspects. And then you can give this pill that can change things, dopamine replacement. We can do surgeries, we can do behavioral things, and it changes over time. It fluctuates during the day. Name another disease that has that complexity
Right.
to it. It's got to be in the top 3, if not the top 1. And so when people say they don't completely understand Parkinson's, I say, neither do I, so I get that.
Right.
But think of it, if I had to sort of blow up the myth, I would say it's not just dopamine
Yeah.
and it's not just the brain and it's
Right.
not just tremor. So I think if people remember those things,
Yeah.
then you think about it. And the other myth is it's not treatable. It is totally treatable.
Yes.
And we have really good things we can do. And so it's totally worth, as you said, getting, attention to it. It shouldn't be thought of as just, oh, you're getting, and I don't say old, I say seasoned, you're getting
Yeah.
more seasoned, right? And this is what happens when you get more seasoned. We need to stop talking in those terms.
Okay, I wanna come back to this really cool thing that you talk about in the book of 0, 10, 100. And I'm very attached to that because I do think that this can help us to get in the next 10 years to a different place with Parkinson's. Is so 0 meaning let's stop all of the things that are in society, like, PCE and TCE and which is like the dry cleaning chemicals that appear to have exposed so many people in the military, as well as people who live in locations near dry cleaners, um, pesticides. We're pesticides and they're still legal. Like all of these PCE and TCE are still legal as well, right?
Yeah, so they're still out there. There is like a ban where they're trying to make them come to an end in commercial use and everything. And we had a red card campaign on our last book to the White House where we overwhelmed the White House with 20,000 letters, red cards
Yeah.
calling for 3 things, a ban on paraquat, which is
Yes.
still, still going. Paraquat's still going. The
Pesticide.
Yeah, as a pesticide, right? We called for increasing research funding by 10 times and maintaining telemedicine after the COVID pandemic. And you can see the insurance companies are reclaiming this, and it's people are losing their benefits, and that's starting to go away. And the idea of 0, 10, 100 is, We talk about this concept in the book that you can't change things if you don't measure them. And business people are really good at this,
Yes.
right? And,
Metrics.
Peter
Yes.
Drucker
Yeah.
and other people have talked about this. There's various, aspects of history where people have learned about this. And so we need to get better at this when it comes to diseases. So we looked at polio, we looked at HIV, we looked at breast cancer, looked at deep dives and said, what are the goals? What should be the goals? And so our three, main goals are 0, 10, 100. 0% rise in Parkinson by 2035. Why do we choose that, Shannon? Well, when we wrote this book called 10 Secrets to a Happier Life in 2012, I used this term called the Parkinson pandemic. And people went nuts. They're like, you can't say that. There's not a pandemic and everything.
12 million people now, right?
Yeah, and so what happened is then this foundation was formed and started funding a really important study, and it was the Bill and Melinda Gates Foundation. Bill and Melinda Gates pushed a bunch of money into the global burden of disease study, where they started to look at this. We looked at the first cut for our last book, Ending Parkinson Disease, and Shannon, you know what? We saw was a projection of 12 million people by 2035 were going to have Parkinson based on that first cut. And people went wild. They said, well, maybe it's not a pandemic, but this is worrisome. Now we should get like that. So, okay, maybe there's something here, right? Then we write the Parkinson plan. We have another cut from the Global Burden of Disease study, thanks to the Gates Foundation. And what did we learn? Well, we have 11.8 million now. Okay, so we're already there. So the zero is let's level the rise.
Right.
Let's level the rise. Let's prevent the preventable. Let's remove unnecessary things from the environment. Let's have the courage to make the changes we need to make. So zero is 0% rise. Let's level this. It is growing faster than Alzheimer's disease now, based on both of those data sets, fastest neurodegenerative disease. The 10 is increase the funding by 10 times, because we've looked at HIV, we've looked at breast cancer. $250 million a year of NIH dollars is not going to do it. We need to be in the billions. We know that. We're going to need to be in the 2 to 3 billion range. And so the plan that we propose, which let me just say may not be the right plan, but hey, you got to have a plan, right? You got to
Yeah.
shoot for something, right? So 10 times increase in the research funding. We call for that in 2020, calling for that again in part of the 0, 10, 100. The 100 is really the saddest one of the three, and that's the fact that we can get expensive HIV drugs and cocktails all over the globe, for people with HIV. Done such a good job, by the way, integrating the care models and everything, and getting navigators and really moving those chess pieces. But when it comes to Parkinson, we have this pill called dopamine, pennies on the dollar, generic, been around for 50 years. Majority of people worldwide can't get access to it. Even if they can get access to it, if you live in Ghana or Kenya or in other countries there where it is there, you'll spend a month's salary just to give yourself this pennies on the dollar, pill. So it's unconscionable to us that we should not have access for everybody for dopamine. So the 100 is there should be 100% access. We've been working with the World Health Organization. They're doing a great job. We're working now with the World Summit for Parkinson, with the Parkinson Foundation, the Fresco Foundation, trying to move this, into a higher level of awareness, because it's unacceptable. I mean, it's something that we should be able to tackle.
And some people can live with Parkinson's. I mean, some people have lived with it for 25 years.
Listen, Shannon, I have people in my practice of all ages, teens, 20s, 30s, 40s, 50s, centenarians, okay? I have people that have lived 10, 20, 30, 40, sometimes 50 plus years.
Wow.
So it really, Parkinson's, we refer to it as Parkinson's disease as, okay? And because if you sit next to somebody, and I know it's cliche to say, you even if you go to a support group, you've met one person with Parkinson, you've met one person with Parkinson. If it is one of the most complex diseases in clinical medicine, everybody has a different, set of symptoms. Everybody's got a different care plan, and some people with Parkinson's are living way longer. We're actually trying to study that and understand that.
Yeah.
And there have been other diseases like cystic fibrosis. By taking the deep dive and understanding who's living longer, what strategies are working across centers of excellence, and applying those, cystic fibrosis has gone from a very devastating disease to much more livable. And I remember I've been telling this story now for 20 years, and they went from like living from 28 to 38. And the last data I saw, now they've got them into their 60s.
Really?
And so thinking about what are the things we can
Yeah.
do different, and then understanding if Parkinson's isn't one disease, if it's Parkinson's diseases, understanding that breadth, but also people need to know this, right? So if you get that designated, that devastating diagnosis, those 4 words, how we deliver them matters. The story that we tell people matters. And part of, like the message here, if anybody is listening, is make sure you're getting care for your Parkinson, because there are some wonderful things that can be offered.
Yeah, and I mean, it's interesting. I was kind of looking at what the number 1 and number 2 cause of death with people who have the diagnosis, and it being like a fall, and then, the aspiration pneumonia, because of the swallowing difficulties. And then, really, there are ways to assess these issues and to help with these issues through OT, PT, regular checkups, seeing where you are with your swallow studies. It was interesting while we were there at Fixel, seeing this fluoroscopy machine that watches you while you swallow. Because if I'm looking at you and you're swallowing, I may not be able to see what's really happening. So by putting you under X-ray, we can actually measure and then have a baseline so that when you come back in 6 months. So these things are not really expensive tools that can really assist people to avoid a death event if
Yeah.
they're starting to decline in that
Yeah,
way.
and absolutely, and we think about this, right? And you think about preventable, right?
Right.
So there's a lot of different ways to think about prevention, but proactive, I like the P word, practical, proactive, preventable, right? Plan, right? You think about those things. It's so important. So if we know one of the leading causes of death is getting pneumonias, so we invented this device. Actually, it was invented by Chris Sapienza, Danny Martin, um, and Paul Davenport here at UF 20 years ago. And they ran a level 1 study, evidence-based study, that if you breathe into this device called an expiratory muscle strength,
We saw it yesterday.
you saw it, sure. If you breathe into the device, you can reduce your risk of aspiration pneumonia, one of the leading causes of death, and you working with the speech. So you have a preemptive plan, right? And you're getting vaccinated for pneumonias and things. You have a preemptive plan to try to prevent these things from happening. Same with, maybe you don't need to see a physical therapist. Like after a stroke, you might see him for 6 weeks in a row. In Parkinson's, it's different. The plan has to be different. We want to spread those out to make sure you've got the plan and we're doing all the right things and you've got the right exercise regimen. Exercise is like a drug, by the way, and every evidence-based guideline now. It wasn't like that when I started 20 years ago. It's really important. So all the things
Important for your brain. Important for your brain.
yeah, it's
Doesn't seem like that's why, but that actually is.
super important, but it's also a body disease, right? It's not just a brain disease. So twice the risk of melanomas, right? Do people know that? So we need to tell them, right? You sweat different with Parkinson. You have a higher risk of melanoma. So seeing the dermatologist, lathering up, wearing hats, important. Twice the risk of osteoporosis, thinning bones, and osteopenia. And we have such good treatments for those. More men than women get this, and people forget, can men get osteoporosis? All the time in Parkinson. Are we screening for it? No, so weight loss, slow weight loss in Parkinson, we need a plan to make sure, we keep you a little above
I
ideal
know, and I've
weight,
heard you
little
say that. Like,
okay?
you need to be a little chunky with Parkinson. We want you a little
I
chunkier.
want your bones to be strong.
Yeah.
But again, Shannon, like we're not having these conversations enough about being proactive, preventative, and early. And so when you went through Fixo and you saw people, we're trying to identify these things early on and really guide a strategy that is going to reduce their suffering, improve their symptoms, improve their quality of life. And by the way, reduction of falls and aspiration pneumonia will save the healthcare systems. Any healthcare system in the world that adopts some plan to do this, doesn't even have to be a plan, some plan to do this, will save in the B's, billions. Aspiration pneumonia and falling are what is driving also the cost to society up. And of course, that's in addition to the suffering of the people
Yes.
and keeping people at home. And so, as you said, when people come in and they're seeing you in the elder law practice and they're having that conversation with you,
Yeah.
and you're thinking to yourself, like, they're like, I need to take a moment and explain, like, this isn't the end of the line. We're here helping you plan your finances, plan your life. A part of your life plan is making sure you have optimization of your health plan.
Right.
And just because you're more seasoned, we don't say older, just because you're more seasoned doesn't mean that you shouldn't have a good plan to try to enjoy as much life as you can.
Right.
Your not just your lifespan, okay, but your health span. How healthy and well, and how much your well-being will be, and putting those things in place. And it's not just Parkinson. I know that we're here talking about
Yeah.
this book and Parkinson, but let me just say that the one thing that has just absolutely floored, Ray Dorsey and I about this, and I was talking to Sanjay Gupta about this yesterday,
Cool.
is the number of people that are reading this book that have, like, no, relationship to Parkinson, nobody in their family. And that was really a very
Yes.
interesting thing. And so it's really, more of this dialogue about chronic disease and where we're going with chronic diseases,
Yes.
and thinking about prevention. What's preventable? What can we do? How can we be proactive? How can we place the right strategies for people in care?
Well, let's talk about prevention because I also love the 25 things to do to avoid Parkinson's. And when someone has the Parkinson's diagnosis, it's still important that they avoid these things, right?
100%.
So, washing your produce, even if it's organic, right? What?
Yeah.
Like, we thought we had it. If we eat organic, it's still possible
Yeah.
for there to be some
So
of this.
I gave grand rounds this morning for the Northwell group in New York, which is this huge academic group that has, gazillion neurologists and everything. And we were talking about this, and one of the docs got on this morning and was talking about, how his friend runs this organic thing, and then he went out to the organic thing, and the guy says, yeah, and watch, we spray this on this, and we spray this, and this is how we do it, and this is how we get to organic, and so yes, if you do organic, you'll get less pesticides in general, but no, it doesn't guarantee your supply chain. You understand, unless you go all the way down to the co-op or to the farm to understand where things are done and how they move forward. One thing that Ray Dorsey and I, as a co-author of the book, like to talk about is we give the example of, just because you have Parkinson doesn't mean you stop doing these things. Here's the example. If you had lung cancer, which, so I hope you don't get lung cancer, Shannon, but if you had lung
Yeah.
cancer, what's the first thing I would tell you to do?
Stop smoking.
Stop smoking, right? Quit, the thing that's caused it and exacerbating those systems, like within your lungs. It's the same thing for your brain, right? And we don't do that because we haven't yet, when it comes to brain diseases, Shannon, we haven't yet evolved, to the point where we have begun to say, you know what? We're tired of cardiology and the Framingham study and atherosclerosis leading on all of these prevention things. We're ready for the neurological diseases. Like, we should be thinking about how we prevent these things, primary prevention of these diseases.
Right.
Once you have the disease, you also need to take away the things that can further exacerbate it. It's just 101. Hippocrates said in medicine, all diseases have causes. And he also said, it's the conglomerates, it's the combination of all of our daily sins that lead to disease. And I think it's still a very important concept. And we're actually coming back to that original concept. So in the Parkinson 25, it's 25 things that you can do whether you have Parkinson or not. And what are my favorite 5 to tell?
Yes, I was just going
Okay.
to ask you that.
Here's my favorite
Okay.
5, okay? Number 1, for sure, get a carbon water filter on wherever you're drinking your water out of. Usually it's in the kitchen sink, especially if you can't afford to get your water tested by the local water authorities. They may not even test for all the things that you need to test for. Like we talked about dry cleaning chemicals and TCE, PCE, all of those things. Carbon water filter, super important. Well water, we always know well water. It has been increased risk with Parkinson. We don't talk about that. We've known it forever, just about forever. Forever is multiple decades in medicine. But, when you get a well, it can get contaminated a lot easier, okay? So carbon water filter, number 1. Number 2, air. Your nose is the gateway to your brain. You have these 2 railroad tracks that go right up your nostrils into your brain, and these 2 railroad tracks are called the olfactory. Olfactory means smell. Okay, not important you remember that, but those connect right into your brain. So what you breathe in is really associated, particularly with Alzheimer's, but also we're now starting to see a drip, drip, drip of studies in Parkinson's disease as well. Air purifiers in your office, air purifiers in your home, particularly if you live in urban areas. Like I was talking to the group from New York City. I think more air purifiers were probably bought on Amazon during that talk I gave this morning. So depending on your locale and your zip code,
Yeah.
and you may not know what your air quality is, So are you living around paper mills and so you can get that information. And so very easy thing to set up quiet air purifiers, change those filters, okay? So number 2 is air purifier.
Yep.
So we talk about water, right? We talk about air, we talk about food, okay? Whether you have organic or not, wash your produce either with copious water, or you can go to your favorite store. Some people like Trader Joe's, Publix, whatever. You can get a vinegar, just wash your vegetables, get the pesticides off. Side means killer in Latin, CIDE. Pesticide, kill the pests. These things came about in the Industrial Revolution not to poison us. They came about to improve our food supply, right? To help poor people, help farmers with their crops. Now, farmers, which is the number one profession in the world, farmers have a higher risk of Parkinson's disease. Why? Because of these exposures. So wash it off. In the USDA, in the US, you're lucky if you get 15 seconds of washing before you see anything, okay? So wash your produce. Number 4 is exercise, okay? Exercise is really important. It's like a drug. We think about that and do what you can. 4 20-minute walks a day if you can. And if you can't walk because of your knees or your back or your balance, then either getting an exercise cycler off of Amazon, or I don't favor Amazon over anything else, but just something you can put in front of you. You don't trip over it. You can sit in a chair and do that 4 20-minute sessions a day. Or you can get a recumbent bike that has a back on the chair here, but of course something that doesn't move like this, right? And do that for 20-minute cycles. We know if you get to 7,000 or 7,500 steps or step equivalents a day, people live longer, they live better, and we know that it helps the symptoms of Parkinson's. And by the way, that's what we call Google data. And what is Google data? Google data is when you don't need a mathematician, you don't need a scientist, you don't need Ray Dorsey, who worked for McKinsey before he was a neurologist. You don't need him to make you a chart to show you this.
We call it Chat GPT now.
It is compelling, right? There's so much data, it's compelling.
Yes.
Number 5 is sleep, of my top 5. We now know there's a system, and we're starting to understand why we sleep. We still don't understand why humans sleep, but we're starting to get there. And we didn't know, Shannon, that there's a system in the brain called the glymphatic system. This is like if you had a party in your house last night and the whole kitchen was a mess, right? When everybody goes home and you spend a few hours like having to clean everything up, put things in the waste disposal, get rid of the stuff that's going to spoil, put all the stuff around. That has to happen in your brain every night when you go to sleep. Okay, so that's part of the magic, and that's part of a system called the glymphatic system that we didn't know existed. And I think of it like there's a whole group of dump trucks that are driving kind of up to your brain, and they're going to pick up all this debris and everything from all the cellular things, all the activities that have happened in your brain, clear things out, get ready for the next day, clear all those toxins and everything. So sleep we now recognize as being important. It's not enough to have one sleep study, if you have a disease like Parkinson, because you ask somebody, how do you sleep? And they either say, good, bad, whatever. You say, well, how do you know? And they're like, well, I don't know, because, the answer is get a sensor, right? Like you got rings, we got watches, we got
Right?
3 of them on.
Yes.
And then you can share that information with your doctor, and we can help you to get to 6 to 8 hours of sleep. You're going to feel better. Your Parkinson's symptoms are going to be better. Your cognition, your thinking, your ability to think late in the day is going to be better. You're going to be less tired, and it's good for your brain. Okay.
Yeah.
So when in the Parkinson 25 for people with or without Parkinson,
Right.
those are my top. Something for air,
Yep.
something for water, something for food, sleep, and
And
exercise.
exercise. And it's interesting because, UF just issued the top 5. They did this study. I'm sure you're familiar with it. And a lot of them are the same. I think the thing for delaying the progression of dementia, and it's sleep, exercise, it's good eating, so Mediterranean diet, calendaring, which I don't know if you'd use that in Parkinson's, but a lot of us with just regular old dementia or Alzheimer's type, it's kind of writing down everything that you're going to do during the day and then checking a box, they found that that somehow delays the progression of the disease. And then full body exercise, you said, sleep, and there's one other one. Oh, brain games.
Yeah,
So
okay, sure.
brain engagement.
Yeah.
Yeah.
Yeah. So these are other things within the 25 too. But I think these are degenerative diseases, right? Dementia, degenerative. There's some that can be due to stroke and vascular disease. But even in what you do when elder law and people are coming in and you notice it, I think people need to, understand that we're beginning to pivot in medicine and realize that these are not, the preordained, way and where we're going to end up like on purpose, that these are the things that can change, and you have the ability to potentially change your trajectory. And so you shouldn't feel like so boxed in, like, well, you know what, it's just going to happen. No, no, no. And it's never too late to get started on these things.
Okay, I want to, before we lose you, because I think we have about 10 minutes left. So, two big issues. The first is I'm still trying to understand Lewy body dementia, or I guess it's something. Do you call it something different when it's a Parkinson's related Lewy body? And I'll just tell you from the elder law perspective, what we're seeing in society is a lot of negative with a Lewy body dementia diagnosis. We see facilities that refuse to accept people with Lewy body dementia, and a general kind of perception out there that Lewy body dementia is really a negative thing, and that we almost try and discourage doctors from diagnosing Lewy body. So I'm wondering, how does Lewy body kind of coexist with Parkinson's, and is that always the type of dementia that we're seeing? So
Yeah.
tell me a little bit about Lewy body.
Listen, first of all, thank you for sharing the story. We've seen this too with, and you could fill in the Mad Lib Lewy body. Like, how is it that we allow this in our healthcare system? It's just, again, another unconscionable thing. Now, what's interesting is Frederick Louis was a neurologist, and
Oh my.
and so he was looking, in a microscope in the early 1900s, and he saw, these bodies that collected, like he could see it in the microscope, and they clumps of things. We talk about clumps of things, like when you sleep, you try to get rid of some of these clumps, but your body, your brain is trying to kind of turn these things over, right? And so a Lewy body isn't necessarily a bad thing. It's like your brain is trying to throw something away as part of the process, but it's way downstream on the process. And so when we think about why we get Parkinson or why we get Lewy body, we need to look upstream to figure that out.
Okay.
We have now figured out what's in those Lewy bodies, and that's where you hear some people throw around this term, this brain protein called alpha-synuclein.
Mm-hmm.
And we learn that from some of the genetic studies, and we tell that story in the book. It's a really interesting story with Polymeropoulos and this whole Greek Italian family that gets Parkinson. So we see these Lewy bodies appear. It turns out, Shannon, that Lewy bodies appear in Parkinson and they appear in Lewy body disease. And some experts believe they're the same disease, and some experts believe they're different diseases. And there's a huge raging debate on this, because if you look at the brain of people, they look similar. The tissue looks similar because they both have deposition of these proteins that the brain is trying to clear, right?
Okay.
And so what we end up with is a very artificial but somewhat useful way to separate them. And that's so when people come in, we take their symptoms and their history. And if you have a lot of thinking and cognitive issues within your first few years of having Parkinson, maybe with some hallucinations, maybe not,
Yeah.
then we start to think about, could this be more the Lewy body presentation of Parkinson disease, Lewy body disease? And then if you get those, or you don't get those at all, but you get them longer, 10, 15 years down the road, people call that Parkinson disease dementia. But if you give it to a pathologist, and we never ask people for their brains until they're done with them, but if you give it to the pathologist and you let the pathologist, cut the brain, and you look at it and you don't tell them anything about, what they had in the first 5 years or the last 5 years, if you don't tell them anything, they can't tell
They
the
can't tell the
difference.
difference.
Okay. So it's on a continuum, and they both have cognitive fluctuations, right? You can get these fluctuations up and down earlier. I think it's unconscionable that facilities would refuse them, but I also think people should know Lewy body has treatments like Parkinson, and sometimes we can use dopamine, sometimes we can't. We can use another chemical called acetylcholine, and some of these people, it can be a really important, to their treatment. There's a higher risk of suicide with Lewy body and some of those issues, and I think that's drives some of the psychiatric symptoms drive people to not want to take them into facilities. But honestly, if they're getting good treatment, they should be, able to be managed
Yeah.
just like anybody else. And really, the idea that we're excluding them is an issue. Now, the other thing to,
And treated with antipsychotic medications,
yeah,
which doesn't work.
yeah, and so
So, like, there you'll find this client coming to you who's been Baker acted out of a memory care unit, and they've been put on Haldol, and I'm like, "Wait,
right.
what?"
So that blocks dopamine, makes all these symptoms worse, and we have better ways to treat. So we're causing it ourselves. And so when folks come to me and they say, I don't want to have a vaccine, I don't want to do this, or I don't want to do that, I say, look, I'm your cabinet advisor. I don't judge you.
Right.
I'll give you as much information as I can, and I will embrace whatever it is you decide you want to do. And it's really important. Second rule: one, I'll be your cabinet advisor and won't judge you. Two, you should never be afraid to tell me what you did do. And you should never be afraid to tell your healthcare practitioner what you did do so we can help you as much as possible. There has been, in the last 100 years in medicine, there have been even, lots of circumstances where in medicine and in doctors where we did things where we thought we were helping people and we didn't. Okay.
Right.
And we have to come to terms with that.
Yes.
We can't just act like, oh, we're the doctors. You should believe
Do whatever we say.
everything that we say, because we learn too. When President Garfield was shot, it was the doctor who was the former slave who was on the side saying, "Don't stick your finger in there, you could infect it," and the other doctor going, "No, I know what I'm doing. I got this." Right? It was doctors giving arsenic,
Yeah.
to people, that for syphilis and other things. So I think it's okay, and we talked about skepticism, and I think it's important for people to ask questions and be skeptical and call us out and have the conversation. And in the end, we'll give you as much information as we can, and we'll support you no matter what you decide. But when it comes to Lewy body and Parkinson's disease dementia, these are complicated things to treat. Be sure that you're getting a second opinion if you need one, another pair of eyes. Make sure you're not taking drugs that are blocking dopamine at the same time you're needing dopamine. Make sure you're not blocking another chemical called acetylcholine that can help your memory when you need the acetylcholine. Make sure that you're taking, the right cocktail and having the right behavioral, treatment so that you can succeed. Whether you have Parkinson's disease, dementia, or you have Lewy body, we should be treating everybody and giving them the maximum
Yes,
amount of care.
absolutely.
Yeah.
Okay,
So Frederick Lewy was a neurologist, just okay.
that's so cool. And thank you for that breakdown. That's one question that people really don't have answers to. So I really appreciate that. And I know we're almost out of time, so I'm gonna ask 2 minutes. Okay. Veterans.
Yes.
We have to talk about veterans
Yeah.
and the impact of, really Parkinson's on veterans being exponentially, I mean, not exponentially, but significantly greater effect on veterans. And why is that? And what can we do better? I think it's really become an epidemic among veterans.
Yeah, so thank you for bringing that up. Veterans and veterans care is one of the Parkinson 25. There's a higher incidence and prevalence in our veterans. We need to take care of them at home and abroad. This book, I think one of the appeals to it is we do a lot of storytelling. The book opens up with two young women, Jana Reed and Sarah Whittingham, who have been very generous with sharing with the world their story. They both went to the United States Air Force Academy, and they had similar trajectories. They both actually became doctors later on after their military, careers. One an anesthesiologist, one an ED doctor, and they both ended up with young onset Parkinson in their 40s, diagnosed within like a month or two of each other. We tell the story of what they're exposed to, like as veterans along their road, and trace their story. And their story is not unique. There are lots of people that were exposed and lots of families that are on the basis. Brian Grant, we tell the story of Brian Grant,
Yes.
the Portland Trailblazer NBA All-Star who has Parkinson disease, who wandered around Camp
Camp-
Lejeune, right? When he was was a child. And so when we think about, these exposures, to chemicals, we have to think about chemicals and pesticides, and we have to try to keep our veterans safe. When we think about Vietnam, we think about what was Agent Purple, which was before Agent Orange, which is what Colin Powell was exposed to Agent Purple. He got Parkinson's disease. And we then think about Agent Orange, which is named Agent Orange, by the way, for the orangeness, orange color of the barrels, not because it turns you orange, but it has dioxin and chemicals that increase your risk of having Parkinson. And you can get benefits for that for
Yeah.
law, and you should get benefits for this. So when it comes to our veterans, we have put them in harm's way. We know when we light up all of the counties and we start to looking, and we're starting to do this research. We're about to do a think tank and Parkinson prevention and trying to move this forward. We're trying to map out this state and looking at where we're seeing, hot spots of Parkinson and where, these exposures are, and what comes up over and over, not only in Florida, but all over the U.S. Superfund sites where there's been spills, and next to military bases where a lot of the trichloroethylene that was used for dry cleaning, right, to get your uniforms and everything, if you drywall it, you dig a hole, you
Throw it in
pour it
the
in,
ground.
it gets in the ground, gets in the plumes, gets under our houses, can even form gas up into the houses for the neighborhoods that are close to that region. And we tell the story of Dan Cannell
Yeah.
in Rochester,
The
New York,
attorney, right?
the attorney, right?
Yeah.
And the that one you probably ring sounds like,
What?
and his whole group of
And he
attorneys.
figured it out.
Yes, and the whole group of attorneys
Right.
got cancer and Parkinson's disease for being next to this. I walked down that street. It's a tragic story.
Yeah.
The Rochester cleaner that's in that book, of the two children that would run around and they loved the sweet smell of the TCE, the trichloroethylene. So when it comes to veterans, the bottom line here is, let's all wake up and let's just come right out in the open. And we have denied them the righteousness of being able to say, yes, we made a mistake. And even with Camp Lejeune, where they're still having trouble getting
Yep.
to that point. We tell the story of Jerry Insminger and his daughter and all the drill sergeant that trained so many people at Camp Lejeune. Let's just acknowledge it and let's give the veterans care, but then let's also do all the things we can do to protect and prevent our next generation of veterans as well.
Because you don't notice for 10 to 40 years. Like, you may have been exposed, like Brian, when he was like 10 or 12 years old, and it's not going to show up for 20 years.
Yes,
So,
that latent period
yeah.
is something that makes it trickier, right? But if you think about it, when the thermostat in your house goes off and you live in Florida you know what that means, right? So if you start messing with the thermostat in the brain, like over time, you're starting to decrease the zenness of the cells in your brain, their ability to function, do the things that they want to do with these exposures over time, and they're impacting the systems. And one of the systems that's really important is the mitochondrial system, which is like the energy inside the cells, right? And paraquat and these chemicals, they go to your lungs. Paraquat goes to your lungs, it goes to your brain, and it goes right to those mitochondrial systems that are so important. And dopamine cells are hungry cells in the brain. They're among the hungriest cells in the brain, and so they pull the energy, and they use a lot. So the mitochondrial systems that are impacted there, it makes sense that these things are linked to what we're seeing in degenerative diseases.
Okay, we've overstayed. We've overcommitted you. So I don't want to get in trouble. I want you to come back and talk to us again. But thank you so much for sharing your knowledge. And, if there's one thing that, I see in just being around seniors all the time and in facilities, it's that we have not appropriately diagnosed Parkinson's.
Yes.
And so, like, please keep doing what you're doing, and please keep talking about it. And 0, 10, 100, you have my vote. Let's do it. We have 10 years. Let's get it done. And I'm counting on you and Kelly and Leslie and Angela to, like, figure out how we move this whole thing forward.
Let's
So
move the needle. We're going to need as many voices as we can.
Yeah.
It's community disease. We tell the stories in the book, but everybody who's listening, your stories matter. Tell your story over and over to get ourselves to the inflection point, the tipping point. We need people to tell their stories, and that's the most important thing. There's a grassroots organization called the PD Avengers, www.pdavengers.com, like the Caped Avengers. And that organization started when we wrote the last book, Ending Parkinson Disease. It just crested over 10,000 members. These are people in communities all over the globe that have kind of come around this message. And, we give proceeds to charity for the book, and the idea isn't about a book, it's about a movement, like where we need to get, and the movement is going to be the people. It's in our communities, you can't meet anybody that either doesn't have a family member, a friend, or anybody that isn't affected by this disease, especially with the expanding numbers. And so tell your stories. It makes a difference.
Thank you.
Yeah.
Thank you so much.
Yeah, of course. Pleasure.
If this episode made you think of someone who might benefit from hearing it, we encourage you to share it. These conversations matter. And to stay connected with future episodes of Thriving to the Finish Line, be sure to subscribe. Thank you for spending time with us.